Okay, so welcome everyone. Good afternoon, good evening, and welcome to the 34th session of the online Optom learning series. Let me just welcome and introduce today's speaker. Today we have Dr. Mustafa Parekh. He is a leading ophthalmologist in India, specialized in cataract, corneal surgeries, as well as refractive surgeries. And he is the medical director of the Lotus Eye Hospital, which is located in Mumbai, India. Not only that, but he is associated with various organizations. To name a few is Cefi Eye Hospital in Mumbai. He is also associated with some other clinics in the Santa Cruz and overseas as well. I mean, he does surgeries overseas as well. And he has his private practice, which is Zen Eye Care, and I have been fortunate to be working with him during my undergraduates and my working life. So whatever I know, I think I really owe to Mustafa sir. And today he's going to talk to us about allergic eye diseases. And he'll take us through what are the signs and symptoms particularly and what are the treatment modalities in general available. So welcome, sir, to our platform. And I think the time is yours.
Thank you. Thank you, Fakhruddin. You indeed been a very good student, one of the best people I've ever come across, and we wish you all the very best. Always, always.
Thank you.
You're doing a very good initiative. You are spreading this medium and using this medium to spread knowledge, and we wish you a very good success in this too. Very good afternoon to all the participants who are there from India, from all of them, from Malaysia, and I hope this is going to be interesting. We're going to be talking about allergic eye diseases. So like any other allergy which is there in the body, you have an excessive immune response. Nowadays, we are all coming across COVID, and we are all talking about immunity, and we are all talking about the immune response. And one of the problems, again, with COVID-19 is an excessive immune response. And allergy eye disease is going to be fitting into one of these things. Basically, any allergen which is there in the environment comes across, affects the ocular surface. You have the immunoglobulin E, which is very important in this histamine production, which is there. The eyes become red, swollen, and itchy, and it is non-contagious. So why are we talking about this, and especially to optoms? Because into our day-to-day life, we are going to be coming across more and more allergens. We are going to come across more and more pathogens, and that is one of the very fundamental condition which we come across. Secondly, in this course of 2 months, I've been doing a lot of teleconsults, and believe me, 50% of the patients who are talking about is of allergic eye diseases. And that is why this is going to be very important for you all also, because you know red eye is very important. A lot of people come across and they say red eye, and you need to differentiate between infectious, contagious, pathogenic, non-pathogenic. The allergens which we come across are the outdoor allergens. You will have indoor pets, and you will have irritants like smoke, perfumes, and cosmetic lenses, which is going to be causing you problems. Now, in these allergic eye diseases, what is the most commonest complaint? Two very most commonest complaint which I would want to highlight is itching and rubbing of the eyes. Of course, these patients will also have redness, will have pain, photophobia, and burning and watering. This is what I was talking about. Post-COVID, we're going to be seeing a lot of red eyes. We're going to be having a lot of patients who are going to have COVID-like picture. Most of these complaints which are there in allergic eye diseases would be also with COVID, and that is why we'll need to take some key home messages from this talk. Now, for example, this patient, a 30-year-old patient coming with itching and chronic red eye. What would you make out by seeing this picture? Very difficult to comment just by seeing this picture, because there could be a lot of cases of red eye, lot of cases. But this is chronic, this is itchy, and so you would want to know, what Is there any complaints? Is there any conditions which we are going to come across? You're going to have a 24-year-old gentleman coming with contact lens intolerance. Differential diagnosis, again red eye, you evert the upper lid, and you see a lot of papillaries. So this is also which is going to be coming across a lot of us. This is also a very, very common manifestation of chronic eye diseases in allergies. It's chronic irritation. Patient coming, playing football. They complain of difficulty to study, difficulty to keep eye open. So these are some of the presentations which we are going to be coming across in our day-to-day practice. Now, the skeleton of this talk, what we're going to be talking about is, we're going to be talking about the basic anatomy. I'm going to be touching on ocular immunology because that is, again, a fundamental and basic of any of the eye conditions which we're going to deal with it. Then we're going to be touching upon the common conditions which we are there in the allergic eye diseases is allergic conjunctivitis, vernal keratoconjunctivitis, atopic keratoconjunctivitis with dermatitis, giant papillary conjunctivitis. We'll have some flowcharts which are there, and then a little bit of the treatment and the take-home messages. So we're going to be talking about anatomy, immunology, we're going to be spending a lot of time, disease, a flowchart, treatment, and what is the take-home message. Now, you're all aware of it, but I just briefly touch it up again. It's very, very important for the eye is the lacrimal glands because they are the ones which secrete the tear, aqueous tear film, the accessory glands, and then you have a tear meniscus, which is a very, very important component of the ocular surface. We all know the various layers of the tear film, the oily layer, the aqueous layer, and the mucin layer, which is close to the corneal surface. Now, coming to the tear film, a very, very important barrier to prevent a lot of conditions in the eye is the aqueous layer, the lipid layer, and the mucin layer. We all know the aqueous layer is made up of water. 90% of the constituents of the tear film is aqueous. It contains mucinous proteoglycans, a lot of growth factors, and it has got very important antibacterial components like lysozymes, lactoferrin, beta-lysine, and so in the lysosomes, what you're going to see is you're going to see gram lysine. How does it help? Is it causes bacteriolysis? Then you have lactoferrin, which acts on the complement system and it prevents inflammation. You have beta-lysine, which ruptures the bacterial cell membrane. It also modulates the normal flora of the ocular surface, and you have immunoglobulin G also. So these are some of the components of the tear film. Now coming to the anatomy, the ocular surface, the first barrier has conjunctiva, you have cornea, and you have the limbus. In the conjunctiva, you have the epithelial cells, and you have a substantia propria. But the most important cells in the conjunctiva are the Langerhans cells, also called as the dendritic cells, or you call them as the antigen presenting cells, APC, which also in other terms could be a type of a macrophage. So this is a very, very important defense mechanism in the ocular surface. Cornea, as we all know, is immune privileged. It has got 5 layers starting from epithelium. We call it A, B, C, D, E. Epithelium, Bowman's layer, stroma, descendants, and endothelium. The limbus, again, a very, very important structure, 1 to 2 mm, adjoining the cornea, and it takes a very, very important part in the allergic eye diseases because it is flushed with vessels. It has got palisades of Vogt. It has got lot of mucoid cells and the lymphoid cells called as the mast cells and laccades. So this is in brief about our. Now coming to the Langerhans cells, which we call them, they're also called as the sentinels of the ocular, the guard, sentinel, the guard of the ocular surface. And what it does is, when it comes in contact with any of the allergens, it, presents the antigen, the material to the lymphocytes, and it aids and it engulfs it. So this is the electron microscope picture which you are seeing here, and these are the cells which we are seeing, the basic cells which are there, and in different allergic diseases they're going to be taking part. The eosinophils, the lymphocytes, the basophils, the monocytes, and the lymphocytes. So these are the very, very important guards of the eyes. Cornea, as we all know, is an immune privileged site. It is also called as an antigenic blotter. Blotter like a blotting paper. So whenever any of the external allergens or bacteria or pathogens come in, it takes it like a blotting paper. Very important thing about the cornea is it is avascular, it has got no lymphatics, but it has got an intact immunoregulatory systems. And this is the quality which also helps us in doing corneal transplants, and it makes the eye corneal immune privilege. You're talking about, yes, so we're coming to allergic eye diseases, and the first statement which we said is a hypersensitivity to any of the external pathogens like dust, smoke, pollens, or house mites. Now, what is immunity basically? It comes from the Greek word immunis, which is free from the burden, and it helps to protect the human body from the external toxic or pathogenic stimuli. So, we've been again, if you take analogy of the COVID, what is happening, we all say you have a good immunity, you are safe, you have a proper immune system, you're good. So basically, it is your body fighting power to take care of the pathogens which come. In allergic hyper disease, as we are going to be talking about, there is going to be an hypersensitivity, excess of your immune response, and which causes the various diseases. So in brief, there are two types of immunity. One is the innate immunity, which we call, which you're born with, or second is the acquired, the adaptive type. In acquired type, you have your bodies which can make their own antibodies, or you could have a passive type if you get vaccinations or you take any of these treatments. In the active own bodies, what you can have is any natural exposure to the antigens. Your body develops the antibodies, and you have again subsequent of these allergens or pathogens coming in, the body will engulf and kill it up. So this is basically two types, innate and acquired. Acquired is also called as adaptive. Immunology, basically, what we're going to be talking is a science of a body response to an antigenic stimulus. Antigenic is again a foreign material, foreign body, dust, pollen, or pathogens. And in your immune system, which fights basically are your cells, the complement systems, and the complements and the various proteins, immunomodulators, which help in your building up your immunity. So as we talked about in the adaptive, the acquired type, you'll have two types, the humoral and the cell-mediated. In the humoral type, you will have B cells, antibodies. The various antibodies which are there are called as gamma in a mnemonic form. IgA, IgM, IgG, IgE, and IgD. So these are the antibodies which are made by the body and which are there also in your system, which in response to any of the germs. So what is the function of the antibodies? They neutralize the toxins, they activate the complement system, and they eat up the microglobulins. These are the different types of immunoglobulins which we talked about. IgG, it comprises 70% of the total immunoglobulins. It's got a short life, and it has got 4 subclasses, G1, G2, G3, and G4. It is responsible for a late immune system in your body. Now, this is very going to be important for us in the allergic eye diseases, and basically for the eyes is a IgA. They are naturally present also in the tears. It is also present in the other body secretions like milk, saliva, urine. They are also called as a secretory immunoglobulins because your body secretes them. They are got antibacterial and they are antiviral. They are either as monomer or dimer. Dimer means 2 strands. Monomer is a single strand. In the eyes, usually it is a dimeric. It's a 2-stranded ones which are found in the tears. IgM. So whenever there is an active, it constitutes 10% of the serum immunoglobulins. This is the antibody immunoglobulin which is going to be fighting the organisms or the pathogens in the first level of attack. IgE, again, very important role in allergic eye diseases. It is this antibody, the overreaction and the oversecretion of IgE, which causes a lot of allergic diseases, and that is what we're going to be talking about. It's got a very, very short life, very short memory, and they're present in small quantities. IgD, very, very least abundant of all, and they're not really involved in the ocular disease. So when we're talking about hypersensitivity, and we're going to be talking about these various diseases, what happens is basically it's a failure of your immune system. And how does the immune system fail? By three ways. One is it over-secretes, over-sensitizes, hyperactive immune system. This is the problem which again happens in COVID, where they affect your lungs and all because your bodies are producing more of the antibodies than what is normally responsible. Or you are immunodeficient. Your antibodies are not being able to, not in sufficient quantities, like what we see in AIDS. Or your third thing is the autoantibody. The antibodies which secrete, they think your body's normal cells as antigens, and they start eating your own cells, like autoimmunity, which we have a lot of other conditions, which we're not going to be talking about, Sjogren's, and there are a lot of other conditions of autoimmunity. So basically from this, we're going to be talking about the first thing on the top, which is there is a hypersensitivity or overactive immune system. It is a term used. Hypersensitivity is a term used to describe the immune system. It has got a detrimental effect on the host. It can cause fever, shock, inflammatory nature. The food muscles can go in spasm. Sometimes you can have anaphylaxis. You have gastrointestinal and the pulmonary disorders, what we see in right now, what we are seeing in COVID, and the fatal circulatory collapse. There are four types of hypersensitivity reaction. The type 1 is an anaphylaxis or atopic. The type 2 is a cytotoxic. The type 3 is the immune complex. And the type 4 is delayed sensitivity. In the ocular, we are really going to be coming across all of this. But in allergic eye disease, it's going to be basically type 1, type 2, and type 4, which we are going to be coming across. And we're going to be talking about it. Now, just to take a little change from your, I've been talking about coronavirus, Corona-19, and we are all going through this pandemic. And just for a little bypass is what happens is basically I don't know this. It's a coronavirus is a RNA type virus, and it has got these glycogen spikes, glycoprotein spikes which are there, and it is these spikes which go and attach to the cells where you have your antigen presenting cells which are there on these receptors. ACE receptors, what they call they get attached and they start giving a problem. So these protein spikes which are there, which binds with your angiotensin converting enzymes, ACE receptors, and these are present in, even in eyes, it is present in lungs, all the mucous part, the heart, the kidneys, and the stomach, and the intestine. So here you're seeing, this is just a small slide, which you're saying is, you're seeing the virion which gets attached to the ACE inhibitors, it comes into your epithelial cells. You have RNA, there's a translation happening, there's a proteolysis, and if your macrophages and lymphocytes can engulf and take care of it, is fine. Otherwise, it opens up, spreads, and then you have the new neurons and you have the spread of these conditions. What is herd immunity? We've been hearing also about it. So it's an indirect protection when 60% of the community gets infected and you have your own antibodies started. Or you can get treated by vaccination also, and you have your normal humoral cells which are there, which increase, your lymphocytes increase, and this helps in spreading further spread into the community. So this was just a little variant from your talks. Again, coming to our topic, yes, we talked about there are four types of hypersensitivity reaction. The category 1, the first one you see, which is in the red box, which is type 1, which is IgE and mast cell respondent. It is the IgE anti-immunoglobulins which are there, and what the mediators are there, leukotrienes and histamine, which is very, very important. They start working in seconds and minutes. The type 4 hypersensitivity, the delayed type of hypersensitivity, is with the T cells, and it takes day to week. So on your right side, you have a lot of these are the tables. And how does this work? So this is in brief. I'll tell you, 4 types are there. IgE is a type 1 mediated hypersensitivity. When your allergens come and binds with the immunoglobulins, they degranulate the mast cells. The mast cells will then release histamine, and it is this histamine and the other the various immunomodulators, which then cause a cascade of problems in the eyes, including inflammation and its various effects. So the type 1 is there. Again, I'll repeat: IgE, histamine release, mast cell degranulation. Type 2, what happens is your antigen and antibodies, they go and attack this and they cause cytotoxic cells. There is activation of the complement system in this, and it is the complement system which starts degrading the various chains of reactions. In the type 3, what happens is your complex of the antigen and antibody, they make a chemotaxis, and what happens is you have a lot of neutrophils, leukocytes, neutrophils which come in the type 3 type of a reaction. And the type 4 is not a humoral type, but it is a cell-mediated immunity, and you have the T lymphocytes which are there. In the eye, you have contact dermatitis or tubercular lesions or graft rejections. So these are various types of reactions of this. This again is a diagrammatic this thing. You can take a screenshot of it. Again, allergens come in, what they come and they get bound with your IgE, that is the immunoglobulins. Then your mast cells are there, the B sites go and then they activate the T lymphocytes, then the B lymphocytes, which gets converted into plasma cell and macrophages. And then there is a release of IgE, which then goes and affects the mast cells, or it can attack and causes eosinophils. So, you know, the mast cell degranulation is the type 1 type of a reaction, but when it gets affected with basophils and eosinophils, these are your type 4 type of a reaction. In recurrent attack, what happens is your cells are already sensitized, and whenever these allergens come in, there's these sensitized mast cells, they start immediately releasing histamines, leukotrienes, protease, prostaglandins, and various inflammatory modules. So this is a type 1 type of a reaction which is there. And what does this cause? This is where it comes as your allergic conjunctivitis. So now coming to the disease proper, you know. So we've talked about these reactions. They are hypersensitivity. Again, I'm repeating. The excessive body response to the allergens, and what are the various manifestations in the eye. The most commonest is the allergic conjunctivitis. It is bilateral. It's sometimes self-limiting. It sensitizes the individual. So once they've got affected with these allergens, maybe pollens or dust mites, they keep getting it repeatedly. And this is specific of seasons. There are two. So in the epidemiology, they have said, okay, yes, around 20% of the population is affected with this. 20% of the population is affected with it. And of this, 60% of the people will also have running nose and allergic rhinitis. Why it is again important in this? Because these are the same symptoms which we'll have with the COVID type of patients also. They'll have red eyes, running nose, sneezing, coughing, and this is the manifestations which is going to be there. Again, going back to the type 1 reaction, this again is a slide, antigens coming in, mast cell degranulations, you will have eosinophils which are there, and this is why you will have two types of reaction, the early phase reaction, which will cause edema, redness, and itching, and in the phase 2, the type 4 reaction will cause you tissue damage. This is the pathognomic of allergic conjunctivitis. Here I would want to highlight is, so whenever you're going to see, just like you saw, you know, those slides in the between, if you go just see this thing without lifting your conjunctiva and everting the upper lid, it becomes very, very difficult to make diagnosis. And in ocular conditions, which you all are also dealing with, very, very important is history, a proper history, and a proper examination. These are two important things for most of your ocular diseases, which you would want to find out. A lot of people, you know, just ask carriers, they show, you know, send you the picture of a red eye, and they expect you to make a spot diagnosis. Would be very, very difficult until you elicit a very proper history and a proper examination. In allergic conjunctivitis, it is mandatory to just not see the interpalpebral area, but you need to also, you know, avert and look into the lower fornices and the lower palpebral conjunctiva and the upper tarsus by averting the lid. When you avert the lid, you see a very classical reaction, which is called as a papillary reaction, multiple fine nodules, pinkish, velvety appearance, differentiating from the follicles which we see in the viral type of conjunctivitis, as you see in the slide. It's not very the same, but you can see these white nodules. So white nodules which you see A lymphoid hyperplasia, these are very typical of the follicles, a type of either a chronic conjunctivitis or viral type of picture you will see. In a papillary form, you will have a velvety appearance, pinkish hue. So this is a very classical picture of all types of allergic diseases. Type 4 hypersensitive reactions, we talked about it's T lymphocytes, and you can have contact dermatitis, graft reaction, flictin, and disciform. All of these are very, very common, which we're going to be talking about. So your acute allergic conjunctivitis, it is usually seen in a young child, itching and watering and chemosis. These are three very important conditions, So whenever you have, again, itching is a very, very, very important complaint and history. You can't have itching in any of these bacterial and viral. If it is itching, that means it's a histamine release, eosinophils. It has to be allergic. Itching along with watering, redness, and then you will have a chemosis also in an acute type of condition. This is again showing you how does it happen. The release of histamine, what happens is two things are there. It causes vasodilatation, that is why you have hyperemia, and this histamine, it stimulates the nerve stimulus, and in 3 to 5 minutes you will have a lot of corneal nerves and the nerves which are there, and you would want to cause itching. So this is the way why you have this complaints of itching, redness, and hyperemia. Management, of course, this is self-limiting, subsides in few hours, cold compresses, antihistaminics are there, and take care of the associated treatment of rhinitis also. This is, so you've talked about allergic. Two types of conditions which are there, seasonal and perennial type of conjunctivitis. Again, the allergens which are there. In a seasonal type, it is going to be basically the pollens, the tree, the grass, more of the geographic which plays into a condition. And the perennial means year round, all year round, throughout the year. So you basically, what is it going to happen? It's going to be a house, dust, mites, you may have animal pets, animal dander, fungal. So this is less common, but this is also equally present. Nasal discharge, rhinitis is very, very important. I have made these red stars again because this is the same condition which you're going to have a COVID type of a patient coming in. But yes, in this, it's going to be history very important. Complaints of itching, which is going to be important, which is going to be differentiating you with these two things. If you do some conjunctival cytology, in these cases, you're going to see a lot of eosinophils. Coming to a second type, a very, very important type, because this can be a sight-threatening vernal keratoconjunctivitis. It can cause a type 1 and a type 4 immune reaction. We talked about type 1 reaction is going to be acute. Type 4 is delayed, chronic. This is condition which is associated with atopy, hay fever, dermatitis, recurrence. It starts in the childhood. Males are affected 4:1 and usually starts in childhood, less than 10 years. It is chronic, goes on till the child is around 20, 22 years, and then it subsides. It has to do something to do with the hormones, sex hormones also, and that is what this duration, which is there 10 to 20 years, itching, watering, redness. This is again the complaints which are there for all types of conditions. In this, what is happening is this is going to be a chronic. There are three types: palpable, the one which affects the limbal type, or you can have a mix. So we're going to be talking about this palpable and the limbal type. The palpable type of a vernal keratoconjunctivitis, you have a very classical picture, and my dear friends, you will miss this out if you don't evert the eyelid. So it is very, very important. If you just see the eye, it may just give you a redness and you may be mistaken. But the moment you evert this eyelid, giant papillae, cobblestone appearance, it's a flat top, diagnostic of vernal keratoconjunctivitis. Upper tarsal conjunctiva only, does not affect the lower tarsus, and it causes the diffuse hypertrophy. You have a discharge, but it is called as a ropey mucoid discharge. It's like a string, like when you're removing it, it just does not come out. The discharge will come like a string, and that is what it is there. A mucoid, a lot of mucin which is there, and then you have the fibrous septate. So this is what it is there, The limbus type, you have a scattered opulescence mounts at the limbus, around the cornea. As you can see in this image, very present in tropical climates like ours. So limbus is thickened and gelatinous. And in this, if you can see these white calcific type white spots which are there. Basically, they are microaggregates of eosinophils and degenerated epithelial cells. If they are more in number, bigger in number, we call it macro. Small ones, micro. Usually the size of this would be a 1 mm and more. How does the cornea get affected? You will have a lot of punctate erosions which are there. You will have a shield-like ulcer which is going to be there. This is these are going to be all inflammatory but non-infective. But once the epithelium goes away, there are chances then, the other commensals, bacteria and all can come and proliferate, and you can have a mixed type of a picture. But most of these are repeated type of these attacks. What happens is it weakens the bowmans, it weakens the stroma, the collagens, and all of these cases, any case of allergic corneal VKC, my dear friends, you have to keep in mind keratoconus. Two things: itching, rubbing the eyes, it affects the collagen fibrils of the cornea, and all of these cases can land up into keratoconus. So these cases, you would want to periodically get them and send them for topography to check the corneal status. And the early stages, we can really prevent them into progression of keratoconus. 20% of these cases of VKC land up with keratoconus. Fakruddin had done a wonderful paper on Downs, Downs with allergic, and he's published and he's done a good presentation on that. He will share it with you all. So he's done a lot of work with Downs patients with VKC and incidence of keratoconus. Treatment briefly: the mild and early would be allergic antidepressive. You'll have steroids, and then you have a surgical treatment. You can take a screenshot of this. So we talked about allergy conjunctivitis, which is two types. You have a perennial type all around the year, seasonal type, and then we talked about the vernal keratoconjunctivitis, which is more of a chronic form, which keeps happening every few months, and then it leads up into different conditions which affect the cornea. You have a variant of this which is called as an atopic keratoconjunctivitis. When you're talking about atopic, that means there is going to be associated other conditions along with the eye. So the picture is similar to vernal keratoconjunctivitis, but this happens in adults. Unlike in vernal, this happens in the winter climate, and this is associated with more of a skin problem, or you may have a lid problem, which is called as an atopic dermatitis. These patients will usually have comorbidities like asthma and rhinitis, and the skin is involved. So the differentiating from vernal to atopic, you will have skin involvement. This happens in adults, this happens in winter climate, and there's associated dermatitis. As you can see again in this slide, you can see most of the joints or your knee or your elbow joints are usually affected in these cases. And you will have a lot of maceration, red lids, thickened, fissured, and it appears very, very dirty, as if a patient has not washed his face. But usually these are all cases of atopic keratoconjunctivitis. They have a papillae which is there, but it's a smooth, featureless tarsus which is there. Usually in these cases, atopic, it's a lower palpable conjunctiva which is affected, and they can go in for an early slim blepharon presentation. Here, unlike in vernal, you will have vascularization which is going to be on the lower part, and you're going to be having the punctate. Unlike in vernal, which is going to be affecting the upper part, here you will have more of a pigmentation in the lower part of your cornea. This is, of course, the image which is taken on the slit lamp. We have put in the fluorescein dye, and with a cobalt blue filter, with a diffuse illumination, you have taken these images. Again, coming to this, this is a small summary which I have done. So, when you have these cases and chronic, and you would want to know, okay, what are you dealing with? There's only one very important test, which is the ocular surface cytology. You take in and you just examine the various cells which are there. And this is a very brief this thing I've said about. If it is neutrophils, then it can shake it. This is the acute type of ocular inflammation. If you see lymphocytes or monocytes, again, lymphocytes, monocytes, type 4 type of a reaction, it is a chronic type. Eosinophils, diagnostic of allergic. If you see mast cells, then vernal conjunctivitis. And if you try to see the keratinized cells, that means long-standing dry eye, Steven-Johnson syndrome, ocular psychiatrical pemphigoid. So these are the few cells which will tell you what type of a condition you're dealing with. I'm going to come across this condition. You see this image of this gentleman, and what you can tell me, you see on the right side, you can see the eye is closed, edematous, the left eye is normal. Now you see this, so this is the picture which you are seeing is what we call as a dermatic blepharitis. Very, very common. You'll see a lot of this in your conditions, especially if you're working in the eye hospital. When you put these dilating drops, some of them are allergic with it. And what happens is, this is the way they would want to present with you. And from within 24 hours to 48 hours, they'll have the whole area swollen, thickened, scaly type of a condition which is there. But it is unilateral. It is going to only happen in one eye if you have put the drops. If you put in both, of course, it's going to be both eyes. But it is going to be a very unique history. You have put in the medications, topical medications, and they've got it. Or sometimes it happens with makeups. It can happen with your contact lens solutions, which contains preservative like EDTA. So this is very, very common and very easily treatable. Also, if you diagnosed enough. So in this case, what would be this thing is, you would, history is very important. Some makeup, some mascara, some medication, contact lens, which is used. Some people, in India, we use kajal. They've changed them as cosmetics or one of these things, and you can. What you would say the treatment is, you discontinue it. This is the word which I've written, re-challenge. So sometimes in our OPDs, when we're sitting in that, and the patients come and tells you, okay, yes, doctor, I don't know, somebody, we had gone somewhere, I had gone for a checkup, some drops were used and I got it. Now in the dilating drops, and there are a lot of drops. So what happens is sometimes we tell them, okay, you're going to be sitting in the OPD, I'm going to be putting the drops and I'm going to see and observe you. So this is to re-challenge them, because if you're going to be, planning for surgery and all, it would be always better to know the condition, which medications they're going to be reacting to him, and then you can avoid them. Treatment for this is cold compresses, lubricants, periocular steroids. Here you can see after the response in 24 hours, the same gentleman, you can see now the swelling is over and he's been able to open his eyes. It takes 5 to 7 days for them to recover and come out of it. Flictinulosis. This is again a very important. It's a type 4 type of reaction which is there. Hypersensitivity, and you will have a localized limbal nodule with conjunctiva around. There's again a history of itching and a foreign body. In these cases, you would want to rule out any systemic conditions. Treatment would be to rule out tuberculosis and deworming. Again, very important is to tell the patient to move. You've seen the localized conjunctivitis. If you see the image on the left, it's very difficult to make a diagnosis. But the moment you look up and you look down and you see the surrounding area is all white and localized at one area, so it has to be 2 or 3 things. One is flictin. It can be second is episcleritis. Third could be a foreign body which is there, which is irritating. So these are the conditions which you would want to do. Flictin will take in because there'll be a history of itching and recurrence chronic. Atomic dermatoblepharitis, as we talked about it. These are all. So we talked about, and again here you can see this is a gentleman with a lot of pigmentation around the hand. They come with a, and then again after you see this last image on when your treatment and you're putting in steroids and perioculars, cold compresses, resolves to a lot of conditions. Now this is the slide I've kept in. Now you see this. This is now, so we've talked about allergic. We've talked about, and here I'm going to be emphasizing this is a case of red eye. But the moment you see the surrounding skin is involved, So you would not say it, but if you go to see it, is only one half of it is involved. The one half of the skin is involved. The other half is absolutely normal. So this is a classical and diagnostic or differential diagnosis of atopic keratoconjunctivitis, but this is herpes zoster ophthalmicus. So again, very important, you do a teleconsult and you see this patient of red eye and you see a ulcer and patient is quite asymptomatic. Whenever you have a lot of symptoms, a lot of redness and watering, then you would have to have a differential diagnosis of bacterial or viral. Here you see the patient is allowing you to open the eyes. Very, the patient has got the ulcer and got this thing. So this could be again a differential diagnosis, could be a shield. But in this case, again, if you see overall, can you see this? Now you can see a lot of pigmentation on in the nose part on the right. Yeah. So this again is a classic case of herpes zoster ophthalmicus. So if you just see the eye, you may not be able to find out the diagnosis. But if you see the whole picture, both the eyes, and you see a lot of pigmentation, you say, yes, this is a recurrent case. This has to be a herpes zoster. In this case, what has happened is this is more of a anesthetic cornea. You call them a neurotropic keratitis. No complaints. Eyes are white. Sensations are lost, and the patient keeps coming to you repeatedly with these type of breakdown of epithelium and conjunctivitis. Differential diagnosis of shield ulcer, but this again is more in the older age group. This is not atopic because there's a unilateral only pigmentation which is there. The other eye is absolutely fine. So this has to be a viral type of a. Again, you have a teleconsult. Patient comes with you like a swelling of the eyelid, and what would you want to make it out of this? A young lady. So what you do is you again examine the eye. You see the eye is totally white. Totally. So this could be angioneurotic edema, type 1 type of hypersensitivity, could be an insect bite, could be again some medications, some medications, and you just give cold compresses, local this thing, wash the eye, and it resolves in 24 to 48 hours. As you can see this image on the right side. Again, this is a very interesting patient, which is come again unilateral. One eye is normal. The other eye, if you take this repeated history, they have this repeated bouts of redness, which is there. It is also associated with joint pains. And also, you would want to suspect in this case a differential diagnosis of uveitis, which you would want to consider. This is again an interesting case. This is a very interesting case, and I would want to again take home message here is always check the history. So in this case, what happens is you see this redness, and the patient consults you, and it's unilateral, and he has got a lot of difficulty to open the eyes. The moment you have difficulty, photophobia, pain, so there is something else which you're dealing then, allergic and all, and you would want to tell him, okay, yes, sorry, we can't consult you. You need to come and see the clinic immediately. And when you see here, you can see this now in this. You can see this patient. He's got a brownish limbal pigment, vascularization, congestion, which is there, and yeah, what do you see here? The surgeon is trying to remove it, and you can see it's a foreign body. Yeah. Very important thing here I wanted to show, why I'm showing you this presentation, is the immune ring. So when you remove this, and you're seeing, when you remove this, and you can see this whitish background edema which is there. This is what is called as when I talked about, a cornea being like a blotting paper. So any antigen which is there, it causes a reaction, a non-infective type of a reaction where it swells up the cornea, is because of these Wesley's ring, which is there, a whitish type of immune reaction which happens, which will go away. So this is not infective. This is a Wesley's type of a reaction which is seen after removal of the foreign body, and 2 and 4 days this will go away with just a little bit of lubricants, patching, and antibiotics to prevent secondary infection. Okay, so now coming to this again, a very important topic for all the ophthalmologists and the opticians and optometrists is giant papillary conjunctivitis. We come across this also a lot of times. What we call, how is it? So this is again a very similar picture than VERNAL, but here you have a history of either contact lens wear or any surgical procedure which is done. And if you go to see, you will have a history of either contact lens wear or any sutures, surgical glaucoma type of surgeries, or cornea where you have an exposed suture which is there. and you have this type of a reaction. The giant papillae here are more than 1 mm, but unlike you see in a vernal type, where you have a flat top, you have a flat surface. Here you have these giant papillae which are round, multiple nodule and in the area of the irritation which is there. You again have a mucoid type of discharge in this cases. So yes, we've talked about all the conjunctivitis which are there with us. We've talked about allergic, we talked about vernal, we've talked about giant papillary conjunctivitis which we come across. Now I would give you this, this is a very important nice one which was in the Japanese guidelines of published in Allergic journal in 2017. And how do you go about it? So you have a history of itching and redness. Then what do you do? So you ask for a history of discharge. What type of a discharge? Conjunctival proliferation means, is it a watery type or a mucoid type? If it is a watery type of a discharge, then you will have to break it up into seasonal type, or it can be perennial or atopic. If it is got along with itching and hyperemia, you have a lot of proliferation which is there, then you would want to break it up into giant conjunctivitis or vernal keratoconjunctivitis or atopic. So this is a nice breakup and a chart which is there, which helps us in our management. Treatment part, avoid allergens. Cold compresses work fantastic in most of this thing. This is a wonderful study, 2014, done in American, published in American Academy of Ophthalmology, where they did a randomized trial, and they talked about a non-pharmacological treatment of acute seasonal conjunctivitis, and where they said, okay, yes, cold compresses and artificial tears will help in resolving a lot of this if it is instituted early, very early in the treatment. 2 minutes. Protection. So people who are exposed, agriculture workers or people who are there, then protective eye gear, this becomes a very important component. And this is also very important. Never use traditional eye medicines. A lot of people, especially in a country like India, where access to the qualified eye care professionals is not there, and patients will go easily, to the chemist and when they just pick up their drops, and usually they start with steroids, and sometimes you can land up with eye vision loss. Don't rubbing the eyes are very, very important. Avoid self-medication, which is there. This is again one slide which is very important. Again, it's talking about a one type of a reaction where you have the antigen allergen which is there. It gets presented to the Langerhans cells, the dendritic cells, which then will stimulate the T cells, the release of cytokines, the activation of B cells, and then you have IgG component which comes in. Mast cells and basophils are there. So, and these are in below where the arrows are there. These are a different type of therapeutic modules which will help and stop the pathway. Based, anti-histaminic, mast cell stabilizers, non-steroidal, steroids, and dual actions, and immunosuppressives. So these are the ones which are there. We're coming to the end of our topic now, and we will say, okay, yes, what are the key allergy, ocular allergy, seasonal? You want to rule out viral infection, vernal, young age, itching, chronic, atopic type. You will want to check up is the skin, any skin dermatitis along with it, and for giant papillary conjunctivitis, history of contact lens intolerance. These are some of the references. So this again, a last take-home message is if it doesn't itch, it's probably not allergic. Thank you very much. You must all be safe during this COVID area. We all take a lot of precautions. This is few of our team, and our team and our optometrists all geared up for a war. And thank you for your patient listening. Thank you. For today.
Okay, yes. Thank you very much, sir. I think it was a very detailed and a wonderful talk. We are a bit of running short in time, so let's take one or two questions.
You take some questions, yeah.
So the first question is, what is the dosage of antihistamines you would recommend, and when should you stop it?
So again, the most important thing in the treatment part is what you would want to know is very important is to wash out. This allergen means when you're talking about it is more of a this thing is there. antihistaminics, there are two types. One is either topical or oral, and it is not a preventive type. It's for acute. When you're talking about antihistamines, histamine, and it is in acute phase. Once the symptoms stop, you stop them. But you have some medications which are mast cell stabilizers, which you would want to continue for 2 to 3 months, like sodium chromoglycate, olopatidine, patidine groups. So these work on both the markers, on the histamine also, and the mast cell stabilizers. So they prevent their degranulation, and these are ones which you would want to use for a chronic time.
Okay. And how would you quickly differentiate between viral reactions and allergic reactions? I think you did cover up this, yeah.
Yeah, I just gave, just briefly, I talked about it, and yeah, this is so again, a viral type, which we are all now facing, and COVID is one of those. The allergic is a prima facie. It's an allergic reaction, the most important thing is itching. It's going to be histamine reline, IgE, and it's going to be, patients are complaining. So that is one very crucial thing you have, because most of them will have redness, and also from the history component, this is very, very important. You would also want to know if you've had any associated complaints along with it. So a viral, invariably you will have a body ache, and you will have a systemic myalgia and different type of condition which may be associated with it. And when you're examining, of course, as we had showed, a very, very classical and a very important differentiating factor is whether you see the reaction which is either papillary or follicular.
Yeah. And how would you differentiate between the atopic keratoconjunctivitis and GPC? Is there any difference in presentation, I suppose?
So see, again, VERNAL keratoconjunctivitis, atopic keratoconjunctivitis, giant papillary conjunctivitis, the clinical picture will be the same except from the history part of it. A VERNAL type will be in the younger age group. They will have no history of contact lenses or no history of surgery. Giant papillary conjunctivitis means there is some introduction iatrogenically, either by way of contact lenses or by way of surgery. Any of the procedures are done. So if that is ruled out, then you are left with atopic and VERNAL. Atopic will have associated dermatitis and the skin problems. Adult onset. VERNAL will be between that very classical from 10 years to 20 years.
Okay, let's just take one last question. There is an evidence which says that certain anti-glaucoma drugs are used for prolonged period. When used for prolonged period, causes dermatitis and allergic conjunctivitis kind of a presentation. So what's your take on managing those kind of patients who are on anti-glaucoma medications? So how would you manage that?
There's a whole topic on that, and that is what is there. Most of the medications now, what we are now dealing with, are preservative free. As I told you about, these are preservatives which are there in these glaucoma medications, which cause a lot of these reactions. And so first of all, you would want to stop it. You've got a lot of plethora of it. You switch them over to a similar molecule or the different molecule. And in the acute onset, of course, you would want to treat them with lubricants, wash. And the moment you stop them in 2 or 3 days, they respond and they come out.
Okay. We do have
now a lot of medications are now preservative free. So, a lot of them are coming preservative free.
Yeah. Okay. We do have a couple of questions. Yeah. Do you want to take some more questions, sir? I mean, is there? Okay. So there's one question which have popped up twice. I think I missed out. Sorry. How can we know which allergen is responsible for a particular ocular allergy by clinical presentation? Can we know by any clinical presentation on how?
No, sorry, can you repeat the question again? I didn't.
Yeah, the question is, how can we know which allergen is responsible for a particular ocular allergy just by looking at clinical interpretation? No.
Very difficult. There are a lot of tests which are there. People do a lot of tests. There are a lot of you basically send them to the allergists. We ophthalmologists don't usually deal with that. But invariably, we don't find out. But we just give a general rule when any of the children or anybody is suffering from it. We say, okay, remove carpets, curtains are not there, avoid pets, avoid potted plants. So these are the things, the environmental, which you would want to take care.
Changes, yeah. How can we go about a patient that complains about overnight unilateral redness with swelling, but there is no itchiness.
Well, good question. Yeah. So what is the age? So again, you take in detail the history. You would want to know overnight if they've used again. So is there any contact lens? What is the age of the patient?
I don't think it's mentioned, but yeah, 19-year-old. I think probably is the case what they have seen. So the person
So
replied is a
19-year-old,
19-year-old.
maybe sleep also. Sometimes what happens is uh, you have a irregular sleep. You get up in the middle of the night sometimes, and if you open sudden opening of the eyelid, you may have a tear. Recurrent corneal erosions, which are there, that can be one of the complaints which could be there. Differential diagnosis, or too much of drowsiness. You got a edge, some trauma, too much of rubbing, or you got a edge hit with the pillow. Unilateral, you would have to think about more of some incidents which has occurred.
Thank you very much, sir, for taking up this one.
Wonderful. Thank you.
Yeah.
I'd love to see
Thank
the
you so
presentation.
much.
Bye. Take care.
Yeah. Thank you. Bye bye, and take care.
All of you, bye. Thank you very much. Thank you.
Yeah, and please stay tuned. We do have sessions next week as well. One of it is on scleral lenses, and the other session would be on frame designing. We will be releasing the speaker's description and the details of joining the meeting soon. So please, stay tuned and check back to your email. There is also some news of collaboration which is going to be announced tomorrow. So probably you will also get to know about that, and I wish everyone will benefit with that. And stay home, stay safe. See you all again next week. Take care and bye-bye.